Yeah, so let's start with our topic. Today is acute breathlessness. So this is one of the most high yield, life-saving, and very common asked, very frequently asked questions in the Oman Viva. So let's start with the scenario. So this scenario is 28-year-old female with a known bronchial asthma presented to emergency department with shortness of breath, wheezing, inability to complete full sentence for last 3 hours. She used her salbutamol inhaler 5 to 6 times with no relief. Now she presented to you in emergency department with heart rate of 128 per minute, respiratory rate 34, blood pressure is 140 by 90, SpO2 88, temperature 37, peak expiratory flow rate 120 liter per minute or 40% predicted. On examinations, she is speaking in phrases, accessory muscle use, bilateral wheezing, prolonged expirations, no cyanosis, no silent chest. How will you manage the case? Yes, Dr. Salika. So you start, organize the question and start.
Based on the history and examination, um, the patient is in acute severe asthma.
Okay.
I would
So I'm
start
writing down
managing.
all your comments. Yeah, you go ahead. Yeah, go ahead. Yes, Salika, you go ahead.
Yes, acute severe asthma exacerbation. Um, Firstly, always airway breathing circulation. Her saturation is 88, so I'd like to provide a O2, and I would like to start salbutamol nebulization, sir.
Okay. So tell me what is the dose of
Salbutamol nebulization.
salbutamol? Airway breathing circulation, you
Salbu
taken care, you started the oxygen. Now you want to give salbutamol. So you give inhaler or nebulization or IV, how you supposed to give?
nebulization, sir. Nebulization salbutamol, 5
Nebulization
milligram.
salbutamol, 5 milligram.
Yes,
Okay,
sir.
how frequently
5 milligram.
you give it and how many doses you give it? Say for example, 5 milligram dose you given to the patient. Are you going to repeat if there is no improvement? What you and how frequently and what
Ye-
dose you supposed to increase? Or same dose, whatever
Uh,
what's concept is. So you had given the 5 milligram of salbutamol nebulization. After 5 minutes, you
yes.
assess, right? There is no response. How
Yes, sir.
you further proceed?
Repeat, sir. Repeat 5 milligram.
Right, 5 milligram repeat, wonderful. After 5 minutes, no response.
Again, 5 milligram. Then
Again 5 milligram,
we can. Mm,
two doses you had given, as you told, I had given two doses. 5
yes, sir.
milligram after 5 minutes,
Yes, sir.
no response. 5 milligram after 5 minutes, no response. What to do?
Then add ipratropium also, sir, because it is acute severe attack.
Tropium, right? You want to add. So you want to add if
Yes,
there is no response, or you have to add by anyway. I mean, you have to add whether responded or not responded.
yes,
You have to add ipratropium. What you do if there is a two doses, no response,
yes,
then you add ipratropium bromide, right? Or you add anyway.
yes.
I mean, whether response I will add, either no response you add. Are you getting my question? Yes or no?
No response. We should add. Actually, starting itself, both the salbutamol and ipratropium. Yes, that's the
No,
little
and you
correct.
have to tell me. So you mean to say you are use given the salbutamol, right? At the same time, you want to add ipratropium bromide, or if there is a no response of salbutamol, then you want to add ipratropium bromide.
Mm,
Sorry,
both.
fine. You think
I think
meanwhile I'll come
start
to
starting.
Fatima. So yes,
Yes,
Fatima, how you manage? How
yes.
you manage this patient? How you manage? You have to speak up both. Yes,
Mm.
Fatima, start.
By considering the signs and symptoms, it is a case of acute severe asthma, exacerbation of acute severe asthma. We have to start with ABC,
Mhm.
and we have to start nasal oxygen with
Mhm.
salbutamol 5 milligram nebulization,
Mhm.
oxygen derived salbutamol nebulization. We have
Mhm.
to wait for 15 minutes.
15 minutes. Okay. You wait
15
for
minutes.
15 minutes.
15
If no
minutes. If
response
there
after
is,
15 minutes,
if the, yeah, if there is no response, we can give one more dose of salbutamol.
so 5 milligram dose you had given 15 minutes, no response. Then,
Then we have to add ipratropium bromide,
okay,
0.5
how much?
milligram,
How much?
0.5 milligram, 0.5
0,
milligrams, sir.
0.5 milligram. Okay,
Uh,
fair enough.
uh, we have to give salbutamol and ipratropium bromide together,
Mm-hmm.
and we have to check for the response.
How do you check for the response? How you check for the
Uh,
response? What are the parameters to be checked in response?
peak flow, peak exploratory flow rate, respiratory
Peak
rate.
expiratory, peak expiratory flow rate, right? So, what is the normal
Uh,
peak expiratory flow rate? What is the normal?
400 to 600, sir.
400 to 600 watt unit? What? 400 to 600 watt? Milligram, ml,
Liter,
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 milliliter,
liter, liter per minute.
400 to 600 liter per minute. Okay. So this is normal, right? So this patient, right? So how you classify, right? On PEFR, this is mild, this is moderate, this is severe.
Mhm.
Yes, tell me.
Moderate peak exploratory flow rate is like 50 to 75 percentage, sir.
50 to 70 percentage of expected, right?
Of no, expected normal.
Okay. And severe is
Severe is 33 to 50 percentage.
okay. So this falls in the severe, right? Here they have
Yes,
mentioned
sir.
40%.
40
So
percentage.
this
Yes.
is 40 in the severe. Okay. Now tell me what is the effect, right, of salbutamol, right, in this patient of acute exacerbation of severe asthma, and what is ipratropium bromide? How both will act on the patient?
Salbutamol is a beta 2 agonist.
Salbutamol, let's see, salbutamol, it's a beta 2 agonist. Okay.
Bronchodilator, sir. It's a bronchodilator.
Bronchodilator. So two question, when it start
Mm.
acting and how long it effects will last for? So you had given the one dose of 5 milligram of salbutamol. So what do you think in how many seconds, minute or hours the action will start? And it remains how long its efficacy? Are you getting me? Yes or no?
Yes, sir. I
Yes.
think within minutes it will act.
Okay, so within minutes you think it is X, right? Okay, fine.
Uh,
And how long its effect will going to last? 1 hour, 2 hour, 3 hours, 6 hour, 24 hours? How long it acts, or it just act 30 minutes only? After 30 minutes, its effect is gone.
I don't know, sir.
Fair enough. Fair enough. Salika, any comment on this? We need to know. You
Um,
need to write down what are the questions coming in the exam. This is how they ask,
okay.
right? So
Okay.
it's
Yes.
a simple question. How long, right? When, how we decide that
What?
when to repeat the dose, salbutamol, right?
Yes.
Or how long we have to wait, right? You had given, say, for example, in fever, paracetamol, 1 gram. So you can't give in next 15 minutes. No? You have to wait. Okay, fine. It's going to act in 1 hour. At least within 3, 4 hours, the effect will comes at peak. If no response, then you repeat or something like that. You understand? So how
Yes,
the
sir.
salbutamol salika is going to start its action? How long it will stay? And what are the side effects of salbutamol? What are the side effects of salbutamol? Yes, Salika. I want three
Tachycardia.
answers. Okay,
Yes.
tachycardia. Okay,
Sir,
fine. Tachycardia.
tachycardia
Right.
and
Hmm.
arrhythmia. Chances of arrhythmia.
Chances
Tachycardia
of arrhythmia.
predisposing to
Okay, fine.
arrhythmia.
Fair enough. Arrhythmia. So what
Then
when it start the effect, right? Patient, you had
yes,
given the nebulization with salbutamol. Within how many minutes
yes,
you expect? If the response
two to
comes,
four, 2 to 4 minutes, sir. Within minutes, it will start.
how many
And
minutes?
last 2 to 4 minutes, sir.
So once you give the salbutamol 5 milligram nebulization, you expect the response in 2 to 4 minutes, right? If no response,
Yes,
then
sir.
probably you repeat it, right? Because there is no response. You
Yes,
waited, right? So what do you think?
yes,
How
sir.
long the effect of salbutamol will last?
Oh, 4 to 6 hours, sir. 4 to 6
Four,
hours.
4 to 6 hours. Fine, fair enough. So you don't want to wait for 4 to 6 hours because it
Yes,
last effect is 4 to 6 hours. Then you don't want to wait for because Fatima is saying, oh, if there is no response, you repeat after 15 minutes. So you why you want to give so fast 15 minutes? You can't wait for 4 to 6 hours because you are saying that the effect will last for 4 to 6 hours.
once threshold is reached, it will, I don't know, sir. You can
Sorry,
say.
I'm not getting your clarity answer.
I'm not getting, I don't know, sir. You can say.
Fair enough. Wonderful. No problem. So one is salbutamol. Yes, Alika, tell me what is ipratropium bromide? Ipratropium bromide. What kind of drug?
Ipratropium,
Like this salbutamol is beta 2
oh,
agonist. Like that, ipratropium is which group of drug?
it's a short-acting muscarinic agonist, sir.
Short acting muscarinic
Receptor agonist.
agonist or antagonist?
Agonist.
Okay. Okay. How does it act? What is mechanism of action? Right? When the effect will start after giving
Yes.
it, and how long the effect of ipratropium bromide would be there, and what is the adverse effect or side effect of ipratropium bromide? Yes, go ahead for answer. You had given the ipratropium bromide.
Max.
What you are expecting, like
Yes.
bronchodilator, what you are expecting? You had given uh, salbutamol, it right? It's beta 2 agonist, so it is there on the tracheal smooth muscle. It dilates the bronchi or bronchodilator, improve the symptoms, improve the oxygenation, and it helps to the patient. This is the action.
Yes.
Side effect is
Yes.
tachycardia, arrhythmia, right? Likewise, what is the ipratropium bromide?
It acts on the M3 receptor, sir. M3
Okay,
of
M3
the
receptor. So where the
yes,
M3 receptor located in the body?
in the
Where is this M3 receptor?
bronchus,
Sorry,
in the bronchioles, in the bronchus, sir. Bronchioles,
in in the bronchus.
bronchus.
Fine. So you
Yes,
get given the ipratropium bromide. So it goes on the bronchus, acts on the M3 receptor. What exactly do? Does it do the bronchodilation by
bronchodilation.
giving the ipratropium
Yes, sir. Bronchodilation, sir.
bronchodilation? So salbutamol and ipratropium, the effect is the same. Both do the bronchodilation.
And decreases the. Oh, I'm a little bit
Sorry.
confused. I forgot, sir.
Fair enough,
Forgot.
no problem. So write down. These are the question. If they ask you in the exam, you can answer. Yes, Fatima. So how you describe the ipratropium bromide?
The ipratropium bromide is a anticholinergic drug, sir. It will reduce the
Anticholinergic drug.
secretion.
It is the
It will reduce
reduce
the
the
secretion,
secretion. Okay.
and it will give the action of bronchodilation also, sir.
So both effects. Secretion is
Both
reduced.
effects.
It's a different, right? Secretion
Yes, sir.
reduced
Both.
or other way around. Can I
Both,
tell that
both, both.
it reduces the inflammation in the bronchial this tree? Fine, fair enough. So you had given the three doses, right? Salbutamol, ipratropium, no response. Salbutamol, ipratropium, no response. Salbutamol, ipratropium, no response. What you supposed to do in next half an hour? You had given waited for 10, 15 minutes, given waited for 10 minutes. So 30 minutes is gone already. Three doses you had given every 5 minutes or 10 minutes to the patient. End of the 30 minutes, nothing much improvement to this patient. It remains the same. I mean, you are not happy. Still, the heart rate after this, instead of 128, it becomes now 130 because of side effect. right? Respiratory rate is still 30, BP same, oxygen is like little improved, 90%, temperature is normal. How you manage this patient now after giving the few doses of salbutamol and ipratropium bromide?
We need to give
Are you going are you
corticosteroids
going
also.
to are you going to intubate this patient right now or no
No,
No,
sir.
sir.
intubation?
No,
Yes or
sir.
no?
Uh,
You give your
no, sir.
own
We need
answer.
to take.
Salika and Fatima, you give your own answer. Don't worry, right? Fatima is correct or you are correct. Whatever you think in your mind, you give the answer. Yes.
Yes.
Yes, Salika.
Sir,
I'm
we
asking
should.
you the straightforward question. Are you going to intubate this patient? Yes or no?
No, sir. No. We
Wonderful.
need to take ABG also. We need to take ABG. I should have said that.
ABG.
Forgot.
So you have done the ABG, right? On
Yes, sir.
ABG, what you are looking for? What you want to see in the ABG? Why you want to do the ABG? You did it ABG. What you are
We want.
looking exactly and how it impacts on the treatment?
Uh, we should know like if there is a respiratory alkalosis is there or acidosis is there. If the patient is retaining CO2 means the respiratory drive is reduced. That time we are supposed to intubate. If the patient is not retaining CO2, then
Fine.
still we can give with O2 support.
Okay. So you give me the three indications of intubation by Dr. Salika and three indications of intubation by Dr. Fatima. Tell me, Dr. Salika, what are the
Yes, sir.
indication of intubation in a patient of acute severe asthma? Straightforward question. Yes, tell me.
GCS less than 8. Any
Sorry.
patient GCS less than 8. Glasgow Coma scale less than 8. Patient unconscious,
So one is patient unconscious.
conscious.
Okay. What else? No, one indication number one. Number two.
Number 2, if patient is retaining CO2, retaining hypercapnia.
Okay. Hypercapnia. Second, third.
Mm,
These all are the exam questions. Write down each and everything. What are the indication of intubation in severe asthma? Okay, fine. Yes, you think of one more things, Dr. Salika. Yes, Fatima.
yes.
4, 5, 6. Tell me. Can I repeat the questions if you don't understand?
No, sir.
Yes,
If
please.
the peak exploratory flow rate is not keep on decreasing below 33 percentage,
Okay, fine.
or
One
pH is less than 7.3,
ABG pH is
acidos
less than 7.3.
7.3. The patient, if the patient is in a altered consciousness
Okay, that is
or
done.
silent chest,
Silent chest. Okay,
mm, and
fine.
hypoxic less than
He is
88.
hypoxic, na? He is hypoxic. So you want to intubate this patient?
No, all these initial treatment, sir. Even after the initial treatment.
So three doses of salbutamol and three doses of ipratropium bromide is done, and still the SpO2 is 88%. Are you going to
Um,
intubate this patient?
no, sir, no, sir. We
No,
have
sir.
to give IVs corticosteroid.
IV corticosteroid. So after three doses, let me ask both of you, three dose of salbutamol plus three dose of ipratropium bromide is given. No response. What is the next drug?
Uh, IV hydrocortisone 100 mg, sir. IV.
Hydrocortisone. Hydrocortisone 100 milligram. If hydrocortisone
Yes,
is
sir.
not available, is there any other drug which can be used? Any other steroid?
Prednisone, oral prednisolone, sir.
PO per oral prednisolone. How much the dose?
40 milligram.
40 milligram. Okay. What else? How when it will going to start the effect? So you have pushed the 100 milligram of hydrocortisone, right, to the patient. How long you wait to know the response, or you don't wait, or what do you do exactly? You had given it the injection.
Still continue
Yes,
with the
Alika.
nebulization, sir. Still
You
continue
continue
the
the
nebulization, sir.
continue nebulization.
Salbutamol
Okay. But it is not acting,
to
na
O2.
doctor. 3 or 4 doses you had given, it is not. Still you want to continue the
O2.
salbutamol? Hmm?
Yeah.
Still you continue the salbutamol? Yes or no? That's fine.
Yes, sir.
Okay, fine. Still no response. You continue, no response. What you do after 15 minutes?
Then BiPAP, sir. BiPAP.
BiPAP. What is BiPAP? What is the full form of BiPAP?
Mm.
What is the full form of BiPAP? Yeah, Fatima.
Positive,
Sorry.
positive, positive airway pressure continues
So that
and
is PAP. What is BiPAP? So it's homework for both of you. Find out BiPAP, indication of BiPAP, what is the BiPAP, how to do BiPAP, blah blah. So basic information about BiPAP, you have to go and read it after my class. Fair enough, right? So now, so you had given everything. Now there is no response. What you supposed to do? Now tell me, Dr. Salika, how you differentiate mild, moderate, and severe asthma? How you differentiate? Is there any definition?
mm,
Is there any classification? Sir, okay, this is mild, this is moderate, this is severe. So how you supposed to differentiate this mild, moderate, and severe asthma?
based on the PEFR value, sir. PEFR that already
Okay, so PEFR, peak expiratory flow rate. How much is
flow
here?
rate.
How much is here? Yes, and how much is here? Tell me.
This is 85 to 50.
85 to 50 is mild.
50.
Moderate,
Then 50 to 35, sir.
50 to 35. And this must be less
Less
than
than
35, isn't it?
35. Yes, sir.
Okay, fine. Okay, you don't have peak expiratory flow rate with you now. Is there any way by which we know that it is mild, moderate, or severe? Or there is no way. This is the only test to know the mild, moderate, and severe asthma.
Yeah.
Sorry, sorry. Yes, Fatima. Any
Vital
any
signs.
other way?
Heart
Yes,
rate, sir.
Fatima.
Heart rate.
Heart
What?
rate. Tell me, mild, moderate, severe.
Less than 120, sir.
Heart rate.
Less than 120. Here,
More than 120, sir.
more than 120. And here,
More than 120, sir.
both are more than 120. Okay. Third way,
Mild, then respiratory rate, sir.
respiratory rate. Okay. Mild, moderate, severe. How much respiratory rate? Mild, moderate, severe.
Uh,
Respiratory rate.
less than 25, sir.
Less than 25 is mild. Okay. Moderate,
More than 25, sir.
more than 25. Okay. More than 25. This is less than 25. Severe,
Mm, Actually, the moderate, severe, and life-threatening will be there, sir, in
okay. I'll
the
add third, fourth
classification.
thing, life threatening. Okay. Leave it. Moderate, severe asthma and life threatening asthma at LTA. Okay. So what is in moderate, what is in severe, and what is in life
This is
threatening?
less than 25, moderate,
Moderate, less than 25.
more
Okay.
than 25, sir.
More than 25. Life threatening,
Um, Feeble chest, sir. Silent chest, silent chest.
silent yes. Okay, fine. Fair enough. What else?
The
How you
ability to
differentiate?
speak, sir. Whether patient is speaking normally or not, whether he's speaking, ability to speak.
Ability to speak. Ability to speak. Okay. What is in a moderate? How moderate people will behave in response to ability to speak here and here? Okay. Tell me.
Moderate, they will speak normally, sir.
Normally they speak. Okay, fine. Normal speak. Severe asthma,
Not able to speak properly.
not able to speak properly. Okay, here
Silent, sir. They can't speak.
they can't speak. Okay, what else? Yes, Alika, any point?
SpO2,
We'll
sir.
we'll see the
Saturation.
you remember what you had the given the answer, then we'll review the literature in detail.
Okay. Sir.
Yes.
Saturation, sir. SpO2.
Yes. Here,
More than 92, sir.
more than 92. Here,
Less than 92.
less than 92. And here,
Less than 88.
less than 88. Fine, fair enough. Anything else? Salika, anything
ABG,
else?
sir.
Remember all your data, we will reevaluate. Yes, no problem. Would you like to add anything, Dr. Salika?
No, sir.
Fine. We need to get lots of answers. These are the few answers, so you both can answer. Right? So
Okay.
one question was that how to differentiate mild, moderate, severe, and life-threatening asthma. You told we'll see the review. How you manage the patient, important. What are the indication of ICU admission? ICU admission. Right? What are the indication of intubation to the patient?
Intubation.
What are the investigation you do for this patient? So this patient comes to you, right? Would you like to do any investigation for this, or you don't need any investigation? History is good enough
Yes,
for
sir.
this. Would you like to do
No,
any
no.
We have to.
investigation? If
Yes,
yes,
sir.
then
Yes,
tell me
sir.
the list. Tell me the list. Tell me the list. Whatever you tell me, I will write down.
The ECG, sir.
Chest X-ray,
Sorry?
ECG, ABGs, chest X-ray, sir, ECG,
ECG, chest X-ray,
chest
ABG.
X-ray,
Why you want to do
Blood
ECG in
glucose.
severe asthma? Why you want to do the ECG in
CPC.
severe? Salika, why you want to
Mm,
do the ECG in this patient who is like severe asthma, standard case? Why you want to do the ECG?
Patient will go for arrhythmia, sir, due to salbutamol.
Okay, so you patient want to do at baseline ECG, or after starting the salbutamol you want to do it?
Baseline, sir. Because
Baseline,
history of to rule out any cardiac cause.
fair enough. Fine. So baseline you do it. It is normal, no problem. Fine, thank you. Then chest X-ray. Why you want to do the chest X-ray in asthma? What you are finding? What are the findings of chest X-ray in asthma? Acute severe asthma. What are the chest findings?
To rule out the pneumothorax, sir.
Rule out the
Pneumothorax.
pneumothorax. Okay. Why you are suspecting pneumothorax in this patient who has a uncontrolled asthma or acute severe asthma? Is there any air entries reduced on any either of the side? Did you find any, I can say, hyper resonant on the percussion? Fine, no problem. So we'll discuss. So you need to, I'm trying to wake up your brain. What are the investigation you would like to do for this patient? So ECG or EKG, chest X-ray, ABG. Any other? Or that's all, it is good enough?
Blood investigation, sir.
Sorry? You tell
Blood
me what
investigation,
investigation.
sir.
which in blood investigation? Blood investigation, what, which blood investigation?
CBC and blood glucose, sir.
Okay, fine. What else?
And electrolytes, sir. Electrolytes.
TBC, English.
Okay, what else? Oh, that's it. Fair enough. What is the role of steroid in asthma, Dr. Salika? Right?
Uh,
Dr.
yes,
Fatima told that she wants to give injection hydrocortisone, right? Hydrocortisone 100 milligrams she wants to give, or oral prednisolone. What I remember, she told 40 milligrams she wants to give. This is what your answer, Dr. Fatima. Am I right or wrong?
Yes, yes, sir, yes, sir.
Wonderful. So why steroid is used in asthma? What is the benefit of using asthma? What exactly it does in
it
asthma? Yes, tell me, Salika.
it reduces the inflammatory mediators, the release of inflammatory mediators, and reduces the inflammations.
So it reduces the inflammation, right, in respiratory tract. Okay. When it started acts after pushing into the intravenous, in how many minutes it start acting, and how long it effect will start.
Mm,
Third question, is it used in acute
yeah,
asthma, right? Acute
yes,
severe asthma it is used, or it is used as a maintenance, or chronic persistent asthma, where what is the exact indication of using the things, right? Indication is
yes,
different and role is different. So indication means when you supposed to use, and once you use, what is the role of this, right? Or
yes,
mechanism, or how it acts, how it helps full to the patient, like salbutamol beta 2 agonist, dilate the bronchus, relieve the symptoms, improve the oxygenation. That's it. Likewise, what is the
mm,
role of steroid in
acute.
asthma, Dr. Salika?
Uh, so for acute severe asthma only, we will use this IV formulation, IV or oral, systemic. In
Okay,
moderate persistent, we will give, if the salbutamol is not controlling, we will give inhaled corticosteroids
okay. So
for maintenance.
inhaled. Okay, so
Main,
maintenance you use oral or inhaled corticosteroid for
inhale,
maintenance. Patient is
in,
fine.
inhaled, inhaled, sir. If moderate
Inhaled.
persistent, yes.
Okay, fine. Dr. Fatima,
Yes, sir.
what is life-threatening asthma treatment? Life-threatening asthma treatment.
We have to start with the oxygen,
So basically ABC and oxygen.
ABC, and salbutamol
Oxygen,
and
salbutamol,
ipratropium bromide nebulization.
right? Saba and Sama,
But,
right? This
yes,
is,
sir.
Yes.
yeah. So this is salbutamol and this is ipratropium bromide. What else?
Back to back 3 times we have to give.
3 times we have to give. Okay, fine.
Uh,
If no improvement, how we supposed to proceed?
we have to give IV hydrocortisone 100 milligram,
So IV hydrocortisone you had given. What else?
and IV MGSO4, sir, 1.2 gram to 2 grams, sir.
MGSO for
2 grams
2 gram,
IV.
2 gram
IV. Over 20 minutes we have to give.
for 20 minutes. How the Maxwell will help in asthma?
Vasodilatation, sir.
Vasodilatation.
Bronchodilation and
So
bronchodilation.
vasodilatation is different and vasodilatation is different. So vasodilatation means in blood pressure. We also used in
And
preeclampsia, right?
yes, sir.
So how you
And
use is a
bronchodilation also,
vasodilator
sir.
or bronchodilator?
Both,
Bronchodilation.
both, 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 sir.
Okay, broncho and vasodilatation. Okay, fine, fine. What else if no response to Maxwell?
We have to shift the patient to ICU, sir.
Wonderful. Shift the patient to ICU. Fair enough. Fair enough. And what is PEFR? How to measure it? And what is COPD? And what is asthma? how you differentiate between this? Do you know, Dr. Salika, how you differentiate asthma? How do you differentiate COPD?
Is reversibility. Asthma is the reversible bronchial obstruction, but
Mm-hmm.
COPD is irreversible disease. And asthma, we can the bronchodilator response will be there, and in the
Mm-hmm.
flow loop, we can see the change in the PFR and after treatment with salbutamol. But in COPD, the response is minimal. And
Mm-hmm.
history also, based on history, the smokers and this is the atopic history will be there. And
Mm-hmm. Good. Wonderful. 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 Great. So now let's dissect this all questions. This is our questions, right? Now see the
yes,
literature quickly. What is the diagnosis? First of all, right? So now, as I told you earlier, this is the practical things when patient comes to you with this symptoms, right? First, they came to you with the symptoms. After symptoms, what we do? We take a vitals and we examine on examination, right? What is here? The main breathlessness. So RSCVS is most important. CNS is also important, and we just do general for abdomen, right? This is called systemic examination, and another is general examination like pallor, icterus, lymphadenopathy, pedal edema, right? Pallor is also important because if patient is anemic, right, he has additional breathlessness because of low hemoglobin. So that is why we do the baseline investigation as well. So this is how for all the patients, right? Symptoms they will give you, right? Whenever patient comes to your OPD, what they say, I have chest pain, I have headache, I have giddiness, I have vomiting. This is symptoms, right? After symptoms, what you do? You examine, right? You do the general examination as quick as well as you do the systemic examination. After sign symptoms, this is the sign, right? So you elicit, you combine it and reach to some kind of differential diagnosis, like in this patient acute severe asthma, say for example, right? This is differential diagnosis clinically. To confirm it, you do some investigation like EKG, you do the chest x-ray, you do the blood workup and basic investigation you do for this patient. Once you do the investigation and then confirm the diagnosis, now differential diagnosis is now confirmed diagnosis. And after doing it, the same time you start the treatment. I told you, one is symptomatic treatment, right? And one is treatment of cause, underlying cause, right? So this is how the flow generates. Am I right or wrong?
yes,
Yes or no?
yes,
Yes, sir.
Wonderful. So this is how we go for this patient. So let's start. What is the diagnosis? That is first question. So this is acute severe asthma. Why? Respiratory rate is more than 30. Our patient has 32. Heart rate is 120. Our patient is, I think, 124. SpO2 is less than 90. Our patient is 88. And peak flow is 30 to 50%. Our patient has 40. So our patient is fitting all the parameters. If you can see in the scenario, everything is written here, right? Are you getting me? Yes or no?
yes,
Right?
sir.
So this all
Yes, sir.
parameters are there. See, our parameter heart rate more than 120, respiratory more than 30, SpO2 is more less than 90, right? Peak expiratory flow is 32 to 50, here 40. So everything is matching, everything is fitting to our scenario, right? So this is what. So we reach to one thing that okay, this patient is suffering from acute severe asthma. That's it, right? Second thing important, what are the features of life-threatening asthma? Because they are very close, right? So mild and then moderate and then severe asthma, like this patient, acute severe asthma. So mild, moderate, severe, and life-threatening, right? So mild, moderate, severe,
Yes,
and life-threatening. So what is the difference? This is acute severe asthma, and what we are discussing is now the life-threatening asthma. Life-threatening asthma. This is important. You need to mug up. You need to mug up. Believe me, it's very important. So it is silent chest. Chest is silent. So bad bronchospasm, even chest is silent. You can't listen the wrong kai or wheezing. It is difficult because it is so badly spasm, and because of that, right, there is a hypoxia, right? So oxygen is go low, Brain is also affected because of low oxygen, altered mental status, peak expiratory flow rate is less than 33. This is very important and interesting things. Here you can see mild tachycardia, here see the tachycardia, here see the tachycardia, but here you can see the bradycardia. Very important, probably because of the brain and hypotension is also there, right? So exhaustion, rising CO2, right? So exhaustion, patient exhausted and rising O2, like a hypercapnia. If any present, urgent ICU plus considered intubation. This is absolutely life threatening. So this is intubation, nothing else, right? Because nothing works in this patient. This is very, very advanced or life threatening asthma, right? So this is, you don't need all criteria. If any present, right? So if your chest is silent, better you do it because you later on will not get time to intubate as well when they collapse, really collapse. So on the first signs, you
Yes.
do it. Altered mental status, patient is absolutely drowsy or unconscious. SpO2 less than 90%. Peak expiratory flow 33%. Patient has a bradycardia. In that case, this is real life-threatening asthma. You need to act very fast within seconds. Sooner the better. Is that clear to you? Yes or no?
Yes, sir.
Yes, sir.
Wonderful. Now this is quick summary table, exam friendly or exam oriented. Peak expiratory flow response, SpO2, and other signs. So if you remember this, then your job is bit easy, right? So how you decide the severity, peak expiratory flow rate, how you decide the severity that it is moderate or severe or life-threatening. So one is moderate, peak expiratory flow is still more than 50% of expected. It is right. If this is going down from 50 to 33, going down severe, so this is moderate, right? Severe and life threatening less than 33. So we have seen when there is a life threatening PFR less than 33, intubate. This is basically intubate. Believe me, intubate, right? Oxygen, already we seen it. Silent chest, we seen it. Neurological symptoms, confusion, we seen it. Bradycardia, we seen it, right? This is life threatening. So you should not miss these two category: severe, acute severe, and life threatening. Here, patient will die fast. Here, you get some time. You get some time in mild, moderate, or where you get the time, right? You can do something. Patient is not well, bad conscious. Patient is conscious, well oriented. Only he is hypoxic. He is like difficulty in breathing. He cannot much properly speak, but he's still, I mean, fine. But severe and life threatening is gone, right? So these two are extremely important, right? Life saving as well, right? So severe asthma, as we seen, right? So life threatening less than 33%, right? Or one third of the normal, right? So this is half the normal, one third half the normal. This is two third normal, kind that, like that only. So this is easy. One third of the normal. This is two third of the normal. This is less than one third of the normal, right? So the peak expiratory flow rate will reduce, right? So I will tell you how to do it. How I will tell you. Just understand the concept, right? Because this is so complex that you sometimes try to avoid the reading, right? Or it's little boring as well. But it's interesting, believe me. So life-threatening is peak expiratory flow less than 33. Oxygen is low. Silent chest means RS, CNS, and CVS, right? RS, respiratory system silent, CNS confusion, cardiovascular, bradycardia. Is that clear? Yes or no?
Yes.
Our
Yes.
case is a severe. In our case it was 40%. SpO2 less than 90%. Our scenario is 88%. Respiratory rate is in our case is 32 to 34 and heart rate is 128. So our patient is fitting to the severe category and this is mild category, right? So we need to know how you classify, how you differentiate, right? So then it would be very important and interesting for you. Once you know this, then you can classify anything and you can know the treatment as well. So now what's the immediate treatment for or immediate emergency treatment in first 10 minutes? So any patient, this patient, we are talking about our scenarios only. We are not talking about anything else. So with first 10 minutes, you have to excellent plan, right? Life-saving plan for this patient. So what is the life-saving plan for this patient in next 10 minutes? when they present to emergency with the same scenario. So obviously any emergency ABC airway breathing circulation should be there. Give 100% oxygen to keep more than 94%, right? So you can give the 3 liter, 4 liter, 5 liter. What is your goal is to keep more than 94%. If somebody with a 3 liter more than 94, fine. Somebody with 4 liter, fine. 5 liter, fine. Right? So try to titrate and adjust the dose to keep the oxygen, right? Oxygenation of the tissue well, right? Otherwise, it acts, hypoxia will act whole body, right? From brain and lung and heart and everything, right? So this is simple, right? This is a ABC for everyone, right? So this is one, number one, right? ABC, right? Once you see the airway, secure the airway, breathing, circulation, IV, you taken, right? You started the oxygen. After that, nebulization is most next immediate step in the management. Nebulization is salbutamol 5 milligram nebulized every 20 minutes for 3 times. Remember this all, each and everything. 4 questions. What a drug? Salbutamol. What is the dose? 5 milligram. How to give? Nebulize. How frequently? 20 minutes. How many times? 5 questions in one line. So nebulization, you need to remember 5 things. Salbutamol, 5 milligram, nebulized every 20 minutes, 3 doses. Is that clear? Yes or no?
Yes.
Yes, sir.
Wonderful. Add ipratropium bromide. Just remember this is 5 milligram. Just add point 0.5. That means 0.5. So this
Right.
is 0.5. Same frequency 3 times. Right? So this is when
Okay, sir.
especially patient is not improving. Obviously, no, then when patient is absolutely fine, you can't add, right? But this is how you have to think. This is how you have to prepare, right? So 3 times means at least 1 hour is gone. 1 hour is gone, right? Salbutamol 5
Yes.
milligram nebulized every 20 minutes. So probably you will look for the response. You look for what are the things to be monitored in vitals. Temperature, it's not required. Pulse rate or heart rate is required. Yes, it is required. How heart rate 128, what happens? Respiratory rate, yes. Then auscultation, then SpO2, these are the key parameters, and the CNS or conscious level. This is also important. So these are the few things you need to monitor for moderate or severe or acute severe or life-threatening. This is general parameter for monitoring to get the response. How did you decide, right? And rest other things are there. You do the peak expiratory flow if patient is able to do it, right? So these are the other parameters, but these are the simple, basic, cheapest, cost effective, and can be done by any doctor. You don't need a respiratory or you don't need to be a pulmonologist to do this, right? So salbutamol 5 milligram nebulized every 20 minutes 3, add ipratropium bromide 0.5 every 3. So rest of the things are done. Only the drug and dose is changed. Salbutamol 5 milligram, ipratropium 0.5 milligram. Both are nebulized. This is nebulized every 20 minute, 3 doses. Is that clear? Yes or no?
Yes, sir.
Yes, sir.
Wonderful. So this is one thing after ABC and oxygen. First thing is nebulization, right? With which drug? So these two drug, then systemic steroid. You don't need to wait in a severe, acute severe asthma. You can start same time. You can start same time. Systemic steroid, right? So IV hydrocortisone, as she told, 100 milligram absolutely given. If not available, or option is 40 to 50 milligram. So you can give the half dose. This is easy to remember. So hydrocortisone 100, oral is 50, right? This can be used, right? Both are steroid. IV fluid maintain if patient is dehydrated, and try to avoid the overload, right? Check for the response after each nab. So you had given the one nab. After that, every 5-10 minutes, 15 minutes, you monitor the response, what happens to all the things. Heart rate reduce or not, respiratory rate is better or not, oxygenation is better or not, conscious level is better or not, chest is open up or not, right? So this is normal bronchus, right? Right. So this is trachea, this is bronchus, and then again is a bronchiole. The small thing is bronchiole, and finally the alveoli. This is 4 things what we need to remember. So main is trachea, right? Main bifurcation is a bronchi. bronchus, or right bronchus, left bronchus. This is bronchus. This is bronchiole. Small one is bronchiole, and terminal is alveoli. Is that clear? Yes or no? So you need to see the improvement in all the things in the chest, right? So this is the first
Yes.
10 minutes you supposed to act in that way. So you used, right? First is ABC, oxygen, salbutamol, ipratropium, bromide, steroid. Maintain the IV fluid if patient looks dehydrated. But that is not an emergency, believe me. Emergency is to open the airway, right? So this is what if poor response? That is what we discussed. What if you poor response? You had given everything. Salbutamol 3 dose, ipratropium 3 dose, hydrocortisone you had given, IV fluid you had started, blah blah. But you are not happy end of the 1 hour, right? 20 23 shot is 1 hour. Are you with me? You both of you with me? Yes or no?
Yes.
Yes,
Yes,
sir.
sir. Yes, sir.
Yes, sir.
So 1 hour or 60 minute patient is not fine, still is like struggling, right? Or patient is not responding the way you think or somehow. So what are the other options, right? So this is very favorite question. What if poor response? What if a poor response? So next, as you rightly told, both of you, IV magnesium sulfate, it is 2 gram over 20 minutes. Consider this is one. So this that was the routine management. This is extra management. You have to think beyond boundaries. Think beyond boundaries means you did ABC, oxygen, salbutamol, ipratropium, hydrocortisone, not is responding. This is credit question in exam. What next you can do? So number one is IV, magnesium sulfate, considered adrenaline, IM, the way we used it for anaphylaxis, right? So let me remind you, anaphylaxis, we did it EpiPen, right? We did it at length, EpiPen or epinephrine we had used, right? Intramuscular we have to use, anterolateral thigh was the things, 1 as 1000 is the dilution, right? This was the things, right? And how much is the dose?
Yes, sir.
Anyone can tell me what is the dose in anaphylaxis?
Point five.
Adrenaline,
Point
wonderful,
point
point
five ml.
0.5 milligrams. So there are again five things. Drug, epinephrine, route, intramuscular, site, anterolateral wall, thigh. Dilution, this, dose, this. Is that clear? Yes or no?
Yes, sir.
Yes, sir.
When you consider, right, if you suspect anaphylaxis, so you don't know, the patient comes with the same patient comes, right? They had taken something 2 hours back and now comes to you with acute severe breathlessness, right? And there is a bronchospasm because anaphylaxis and this asthma, you if you compare it, looks like same, right? But there is a
Yes.
absolutely history of exposure, epinephrine, both the mechanism of action, right? So if you suspect that there is some kind of anaphylaxis, then drug of choice is adrenaline. Same way. So you do the ABC, you give the oxygen. If there is a history of, first give the adrenaline or epinephrine, adrenaline. That's it. That's it, right? If not, if you are not considering this is not a anaphylaxis because this is a known case, chronic asthma now presented with acute severe asthma or exacerbation, right? So in that case, number one is IV magnesium sulfate and second is IV aminophylline drip. This is for suspected anaphylaxis. Is that clear? Yes or no? So IV
Yes.
aminophylline,
Yes.
if not improving and no contraindication, right? So this is the things which you need to know, right? So concluding my talk, right? Airway, breathing, circulation for this patient, oxygen for this patient, SABA and SAMA is for this. SABA is salbutamol and SAMAS, right? Short acting muscarinic antagonist is ipratropium bromide, right? Then steroid, then no response, then magnesium sulfate, and then aminophylline drip. If you suspect it, it is anaphylactic, bronchospasm, and acute severe, you add the epinephrine. Are you getting me? Yes or no?
Yes, sir.
Yes, sir.
Brilliant. So what is a so this is the credit question. Credit question. Believe me, this is credit question. You need to remember, right? Our PowerPoint
Yes.
and this video is there, so you can revise it again. But it's important. Indication of the ICU. I asked you the questions in earlier. So despite of giving oxygen, still patient's oxygen is persistently low, less than 90. I admit in the ICU. Peak expiratory flow is less than 30. Admit in ICU and probably you intubate as well. Rising PO2 means CO2 narcosis or hypercapnia, exhaust, confusion. and need for ventilatory support, right? So these are the things where you supposed to think of admit patient into ICU, not in the ward. These are the unstable patient, right? As I told you, when to intubate. So these are the all classical thing. Altered mental status because of poor oxygenation to the brain, inability to speak. He cannot speak it, right? So bad asthma, severe hypoxia despite of oxygen, PaO CO2. So either oxygen is going down or CO2 is increasing. So there is a difference. This is called hypoxia. This is called hypercapnia. Hypercapnia. Hyper means high and capnia means oxygen, carbon dioxide. Hypo means low and oxia means oxygen. So here low oxygen, here high carbon dioxide. Are you getting me? Yes or no? Silent chest
Yes,
or
sir.
Yes,
apnea,
sir.
and cardiac arrest, obviously. So these are the few things where you supposed to think of intubate the patient. So you should have clear cut clarity in your mind when you supposed to intubate. It's absolutely life-saving decision when you are in the emergency room. If you miss this part, if you miss to admit the ICU, you just keep giving without confidence or without response, then patient eventually die. So you need to take quick action, so we have complete crystal clear clarity that these are the indication where I supposed to admit in ICU and intubate as soon as possible. Right? When in which investigation we seen it, ABG will see the oxygen as well as carbon dioxide. So hypoxia and hypercapnia. SS mainly we are interested in CO2 retention. Right? Chest X-ray to rule out the pneumothorax and infections as well, not just the pneumothorax. CBC, we are looking for some kind of infection. So here you can see the high WBC count or white blood cell count, especially when there is a septicemia, but they usually have neutrophilia, high fever, right? Temperature. So which is not there, but this is a basic investigation. Electrolyte, you told it, and PEFR, pre and post treatment. So PEFR, in our case, PEFR, say for example, expected is around 40%, right? So after giving salbutamol, tropoamide improves to 60%, improve after 30 minutes of treatment, 80%. So this is improved. So pre-treatment and post-treatment PEFR is important to assess the response of the patient, not just the baseline. How are you supposed to know that this patient is responding to this, right? What is the role of the steroid as we seen? So we are seeing it absolutely in the high yield literature, right?
Yes.
Fine. So this is what is the role of steroid. So what is the role of steroid here? The reduced airway inflammation, right? The main thing is the reduce the
Yes.
inflammation. Second is prevent relapse. Prevent relapse. Patient prevent the relapse, right? To prevent the relapse. Onset of action is 4 to 6 hours, usually 4 to 6 hours. So it is not a good drug for emergency, but you need to start because when you give it start acting, so within 4 to 6 hours, the onset of action. Onset of action will start in 4 to 6 hours. So when patient has SpO2 of 85, respiratory rate of 35%, peak expiratory flow rate is like 25%. At this point of time, if you give steroid, it won't impact immediately to the patient, but you need to give just to prevent. What is the important is to prevent the relapse. So you can give at the same time, but you cannot expect the steroid response. So fastest thing which saves the life is SABA, short acting beta agonist. That is salbutamol. This is number one. This is rescue. This is life saving. So whenever any patient comes to you, acute severe asthma, or very bad bronchospasm, blah, blah, or hypoxia, try to give nebulized salbutamol. That is the number one. After that, you get salbutamol, ipratropium bromide, fine. You give steroid, fine. But don't expect the effect immediately. Are you getting me? Yes or no? At least tell me yes or no.
Yes, sir. Yes.
So
Okay.
onset
Yes,
of
sir.
action is 4 to 6 hours, not immediate like salbutamol, which is in the minute. We'll see it everything. Continue for 5 to 7 days. So once you had given, once the attack is subsided, you give 5 to 7 days, which really reduce the airway inflammation and it prevent the relapse. That is extremely important, right? So when can patient can be discharged? That is question. So PEFR is improve, oxygen improve, symptoms improve, CNS is improve, right? And you can given the discharge medication, short acting beta agonist patient for the acute rescue, inhale corticosteroid plus LABA for the prevention, right? And oral steroid taper, right? If needed, or when you started the patient on oral steroid after 2 3 days, right? You give it for 1 week or then you later on taper it, right? So this is what the thing is or flow runs, right? So this slide we already seen it, right? How does this slides works? So we have seen this slide already, PEF, how we do it, PEF. And this is the beauty of the whole talk. This is the beauty of the whole talk. Just two slide, if you remember, end of the day, your 99% job is done. 99%. So now let's start with the flow. How you supposed to manage. So acute asthma, patient acute severe asthma, right? Assess severity by airway, breathing, circulation, vitals, respiratory rate, PEF, right? So when patient comes to you in the emergency, acute severe breathlessness with this history, right? You need to assess in which category they falls, right? So three category we have seen in moderate. So PEFR is more than 50 here 33 to 50, and here less than 33, right? So if you remember, this is better 30. Sorry. So severe, just remember 33 to 50%. If it is more than 50%, it is moderate. More than 50%, moderate. Less than 33,
Moderate.
sorry. So more than 30, less than 33 is less than 33 is life threatening. More than 50 is a moderate. Is that clear? In between 33 to 50% is a severe. Are you getting me? Is that easy now?
Yes, sir.
Right?
Yes.
So you need to remember only one number for PEF, 33 to 50%, right? So this is severe. If they can do better than 50%, better than 50%, it is moderate. If they do less than the severe, less than severe is super severe or life threatening. That is less than 33%. Hold on for 1 second. So this is what the thing is. So is that clear to you, Dr. Salika and Fatima? You need to remember one,
Yes, sir.
55.
Yes, sir.
Here the same
Yes,
way.
sir.
Here the same way. Remember 92%. More than 92 is moderate and less than 90 is severe, life threatening. Here dyspnea cannot speak, right? He is talking normal. So better is talking better, right? So here talking cannot talk or speak, and here silent chest. So this is how you did it. So right. So this is how we do it in the emergency room, right? So when patient comes to you with a breathlessness, you assess the severity, moderate, severe, or life threatening, right? You do the basic investigation, P for pre-treatment and post-treatment. You did it, right? So do it pre-treatment. Now patient is pre-treatment. So just to get the idea, airway breathing, ABG, if for severe, not for moderate, it's fine if you don't do it, right? Chest X-ray, baseline, EKG, electrolyte. You told very well now. Now it's immediate treatments. These things goes together. It is not one by one, it goes together. So when patient comes to you, everything is like a circus, right? Everything is, everybody's playing his job. Somebody's collecting the blood, somebody's asking for the ABG, somebody asking for the chest X-ray, somebody's doing the ABC, somebody's giving the oxygen, somebody's preparing the nebulization. Within 5 minutes, everything is done. Are you getting me? Yes or no?
Yes, sir.
Yes or no?
Yes, sir. Yes,
So
sir.
I move my clock forward. So immediate treatment. We did it mild means moderate, right? Severe or life threatening. We seen it. After that, what we did some basic investigation and treatment. Now comes the treatment. So oxygen maintenance, SpO2 94 to 98. Nebulize every 20 minutes, 3 doses, salbutamol 5, 0.5, right? Add in a severe case. So severe case is there, you add it, but there is no harm it as well, just for your kind knowledge. So don't be academic if you don't understand, add it. That's it. There is no major harm. Got it? So salbutamol and ipratropium bromide, right? Then systemic steroid, IV hydrocortisone 100, or. You don't need to add both. Oral prednisolone, half of the 100 is 50, so 150. Reassess after each nebulization. How and what you reassess? Respiratory rate, reduce or not? Heart rate, reduce or not? Oxygen, improve or not? PFR from 35 to 15 is there or not? Ability to speak that. This is all for all moderate, severe, or life threatening, right? So there are two possibility, right? you had given, right? So you had given the ABC, oxygen, all those steroid. You assess two possibilities, whether patient improve or patient not improve. Are you getting me? Yes or no?
Yes,
Sir.
sir.
Wonderful. Let's check improving, not improving. If it is improving, good news, continue nebulization, right? Nebulizing because improving, na, hourly. Continue naps hourly, right? Earlier it was very 20 minutes, right? Now continue hourly, observe for 1 to 2 hours, right? And if everything is fine in next 4 hours, you can discharge the patient, right? Discharge the patient. When to discharge the patient, right? So discharge when stable. What do you mean by stable? PEFR improve, SpO2 improve, symptoms improve, right? Try to teach and learn how to do the inhaler technique. Start or continue inhale corticosteroid for prevention of relapse. Action plan and follow up you need to do. This is very important and beauty. As we seen it, not improving. You had given the ABC, oxygen, ipratropium, salbutamol, and steroid. You had given no improvement. What to do? We have seen it already earlier. Magnesium sulfate 2 gram over 20 minutes. You have to give it, right? Aminophylline you have to give it if needed. Consider epinephrine if you are suspecting anaphylaxis. If there is a still poor response, you have tried everything for this patient, then don't get stressed. Admit the ICU patient. This is refractory. Refractory means not responding to the primary treatment. It is refractory. So patient admit the ICU, high risk of death, right? If less than 90 sp2 in spite of oxygen, right? Rising CO2, exhaustion, CNS symptoms, silent chest, cardiopulmonary arrest risk. If you feel that this patient is going into the arrest, admit him. Admit him in the ICU. Don't worry, right? And after that, right, if there is a still poor response after admitting in the ICU, right, intubate it. Simple, intubate the patient, right? Especially when to unable to speak, exhaustion, CO2 retention, drowsy, silent chest. So you already seen the criteria, right? And this is what the thing is. SABA is just for your knowledge. SABA means short acting bronchodilator. SABA is short acting bronchodilator, right? And LABA is long acting bronchodilator. This is LABA, SABA and LABA. SABA works for 4 to 6 hours. It start in minute. So onset. So once you give the salbutamol, within minute fast, they start acting and their duration of action is 4 to 6 hours. Here LABA, right? Onset, moderate onset, or slower than SABA. Obviously, that is why this is right and works for 24 hours. So this is mainly used for the maintenance, not the immediate rescue. So use is rescue. You want to save the real life. Acute relief, it is SABA. Maintenance, long-term management is LABA. Is that clear? Yes or no?
Yes, sir.
Yes or no?
Sir.
Yes,
Right.
sir.
So these are the few. We will repeat this lecture again. Don't worry. I want you to give the concept type, short acting, right? Salbutamol, terbutaline, and SAMA, SABA and SAMA. So just for your kind knowledge, I think Dr. Salika told or Fatima, short acting muscarinic and
I
agonist.
told
So
the
it's not agonist,
antagonist. Yeah, yeah.
antagonist. Just for your knowledge, just
Yes,
for your
sir.
knowledge, just for your knowledge. So this is agonist, this is antagonist. Salbutamol, ipratropium bromide, right? We are clear, right? We knows now everything, dose and everything. Long acting means LABA, long acting beta 2 agonist, and LAMA, long acting muscarinic antagonist. So here salmeterol, slow onset, that is why not used in emergency. Action is 12 hours. Formoterol, comparatively fast onset, effect is 12 hours. Idacatrol, less used, but this is the things, right? So if you don't remember each and everything, remember only one. Salbutamol, you must know, right? In short acting and salmeterol, you need to know. So if they're asking, tell me the name of the LABA, then you should not be blank. Okay, LABA, salmeterol is a long acting, right? Its mechanism of action is slow. That is why not used in emergency. Effect lasting for 24 hours or 12 hours. So it used in the maintenance. Is that clear? Yes or no?
Yes, sir.
Right? So,
Yes.
so this is what we have discussed so far. So this is what the things. So that's it. So for my side, I want still to get you the more clarity, right, about this topic because it's a vast topic. I understand. right? So it is not done in a one go. So we probably take another one more lecture for this acute asthma or acute exacerbation of asthma. I will come up with the new scenario. So you need to prepare well once again, probably tomorrow or day after. I will announce the date probably by tonight. So get ready yourself mentally by same time tomorrow. But I will confirm with my schedule and time and I'll get back to you. Meanwhile, I want you to mug up each and everything. This is, see, I mean, absolutely high yield point we are going. Anaphylaxis, very high yield, right? Chest pain, high yield. Acute breathlessness, very high yield, right? Pulmonary embolism, high yield. So these are the absolutely frequently asked question. If you are prepared well with 10, 15 topics or anemia, high yield topic. Sickle crisis, high yield topic. So if think that if they ask you the same question, how confident you are, isn't it? Yes or no?
Yes.
Yes, sir.
Right. So that's all for my side. We will discuss the other part of the breathlessness probably by tomorrow or day after. I will confirm the date. Both of you are available tomorrow or not?
Yes. Yes, sir, I can.
You both, Salika and Fatima.
Yes, sir.
I am available, sir. Yes, sir,
Wonderful.
both.
So both of you at okay with this same time, 7:15 Indian time.
Yes, sir.
Okay, sir.
Wonderful. So I'll confirm it. So before I end up my session, give me a quick feedback. How was your mindset before starting the class and after the class? Quick.
Very practical, sir. Absolutely practical and refreshing.
So you got more clarity, Salika?
Yes, sir. More clarity.
Wonderful.
And I understood mistakes, where I'm making mistakes, everything.
Wonderful. We need to
Similarly.
work on our mistake. This is how we improve. And
Yes.
second, yes, Fatima. How was your
Yes, sir.
experience? What was the
Uh,
concept earlier and now?
very clearly explained, sir. Like the
Right?
severity, how we have to assess uh, by the vitals and the PEFR, everything
Wonderful. So
in
I
a
want
quick way.
wonderful. So this is more, I mean, you will not forget because discussion brings the clarity, isn't it? Otherwise, we are
Yes, sir.
reading every day, but you understand, discussion is important. So I want and wish you both again read whole the asthma things from website or our material or this class or whatever, right? And we'll meet
Yes.
once again by tomorrow, most likely, but I'll confirm the times. Thank you very much. Good night
Okay, okay,
and
sir.
enjoy your
Thank you.
evening.
Thank you
Thank
so
you.
much. Thank you,
Take care.
sir.
Bye bye.
Thank you so much, sir.